concern. We're dealing with identifying and applying appropriate rehab assessment tools and methods to determine the outcome of treatment. So remember, as we start going to G codes and the functional reporting, we'll need to pay attention to those kinds of things. We're going to be using electrical stimulation primarily for fatigue, spasticity, pain, and mobility limitations. So that's lots of information. I'm backtracking a little bit so you understand when to provide that input as far as the electrical stimulation is concerned. So remember, we've got several different kinds of diagnoses, and so when can you actually treat? It really does not matter in which diagnosis you end up treating the patient. My plea to you is that you start as early as possible, only because you'll see. So let's move on. So diagnosis, again, there's no particular definitive diagnostic tests. I think all these information might be a repeat from Dr. Pardo, but I think it bears repeating so you understand that it's really a difficult diagnosis to literally put down on paper. Based on medical history, signs and symptoms, requires evidence of lesions at least in 2 distinct areas of the central nervous system, evidence that the lesions have occurred at discrete points in time, and no better explanation in some instances. So if the MRI is abnormal in 90% of MS patients, so guess what? Again, discrete one to the other time, it should give you a better idea of what it is. You can do a lumbar puncture, so you get the cerebral spinal fluid with oleclonal bands occurring. The other thing is a visual evoked potential. Visual evoked potential comes in nicely, especially when you're trying to determine an early diagnosis for MS patient that doesn't show up in an MRI. Symptoms that you might feel or might think that you have MS, mostly fatigue, bladder and bowel dysfunction, sexual dysfunction, cognitive difficulties, depression, numbness, tingling, paroxysmal symptoms, muscle weakness and balance issues, vision changes, spasticity and pain. So as you can tell, this is pretty much can be similar to other individuals out there that might have a similar pathway. So just be aware that it can be same as some of the other neuro patients. Typically, management and treatment with MS patients, you're dealing with treatment of the acute attacks. Symptom management and what have you typically has to do with medical interventions such as medications, etc. Disease modification, again, through the medications, psychosocial interventions, education, and last but not least, rehabilitation. So that's what we're going to spend most of our time on. What is the natural window of opportunity for treatment? And the answer is, if you'll take a look at this particular slide, and hopefully you can see it, is that as it progresses through the process to secondary progression of MS, you're looking at whether it's acute or not. It's getting worse and worse, so to speak. If you look at the cognitive dysfunction, which is that particular line, not cognitive dysfunction, level of disability, it's getting worse all the time. If you look at accumulated MRI lesion burden, obviously it's getting worse all the time too. So when should you treat, right? Here it is, worse again, cognitive dysfunctions getting worse, and the brain volume's decreasing. So again, suggestion might be to treat them up front so we can get the pieces in place so that they can get used to the process and therefore get a better outcome. Okay. Are we all still not hearing the presentation at all, or are we all good? I've got some folks with no volume. Can you come up, Anita, again, and Deborah? Okay, I'm good. Right. All right, we'll keep going. All right, the natural history of MS can assist you with treatment decisions as well. Realize that MS never sleeps. Axonal loss accumulates early and silently, so we have to pay attention to making sure that we deal with this whole process up front. There's irreversible physical and cognitive disability that can occur rapidly. So that's why you want to deal with the function up front, early. Early disease behavior may predict long-term outcomes. So if we can get them to establish a nice exercise regimen or deal with the pain or deal with the spasticity up front and early, then perhaps the prognosis is a whole lot better. The goal in the process is to go ahead through monitoring and targeting risk factors to help make that difference again. Evidence of increased disease activity or progression calls for consideration of the treatment modification. So as you see the disease change, as you go from one level to the next, you need to pay attention to this so you can change your treatment protocol. Remember that invisible versus the visible MS. We only see the relapses. We see the physical disability. We see the cognitive impairment. Realize that's only 1/10 of the problem. Everything else that might be below in this iceberg ideology is that you still have brain atrophy. You still have the MRI lesions that we don't see. You still have the cognitive impairment that we don't see. So potentially the patient is at risk if we don't deal with those pieces of the puzzle. And I think, as we talked before in the previous two presenters with Amy and Dr. Pardo, I'm sure they've said you need a team approach to get this done. So we're only dealing with the physical portion of this whole process. So realize that if you don't deal with the cognitive piece, you will also not get any outcome or poorer outcome. So multiple sclerosis is a diagnosis that never sleeps. There's an axonal hypothesis, in which case axonal loss causes permanent disability, and the key here is permanent disability. So when does axonal injury occur? Begins at disease onset and correlates with the disease of inflammation and lesions. Throughout the course of the disease, axons are lost, so it gets worse as time goes on. Axonal damage occurs in periods of clinical quiescence, and patients do not have the sustained disability until redundancy and plasticity is exhausted. So never give up on your MS patient either. So treat early and get them going all the way through. As with other problems, it is a circular issue. So if we have fatigue and depression, you have decrease in the exercise ability, you have increased spasticity, increased constipation, travels to increased bladder problems, decreased sleep, cognitive function. This series of problems continues over and over again. So like with pain and everything else, your goal is to actually break this cycle. All right, somehow break that cycle to be able to improve their function. Obviously, symptom management is done by medications. If you're not familiar with them, please get used to the different medications that exist out there, whether or not it's injectables or whether or not it is pills at this point in some instances, or whether or not you're getting infusions. Be aware of what those side effects can be for any of those medications. The psychosocial interventions, education with the patient and family are very critical. If you're leaving the family out in this process, please include them, because they are going to be your help. They're going to be your eyes and ears in certain circumstances. Let's jump to the surgical interventions. I think Amy talked about the baclofen pump for spasticity. We'll talk about some options as we go along before that. And then lifestyle modification. I'll give you an example of diet. One of my MS patients drinks nothing but Diet Pepsi or Pepsi all the time. That's all that she ingests for fluid. Not a good thing. So certainly pay attention to those kinds of things, and if you feel like you need to refer them out, then that's what you need to do quickly. Definitely talk about energy management. Talk about the glass that's always dribbled out rather than emptied all at once. Dealing with work accommodations, stuff like that. In rehab is a structured problem focus, interdisciplinary. Cannot emphasize that it's interdisciplinary enough. We want to enhance the function following an exacerbation. So if they get worse, how do we deal with that little bit of worseness? Let's get moving with that process. You want to be able to identify appropriate assistive devices. That's a big balk with patients that early on in the process think, I can get away without an assistive device. Remember that an assistive device is exactly what it is. It's an assistance. It's not a hindrance, and it's not to be viewed as a means, oh, I'm getting worse. You just have to deal with that psychological affect and get that taken care of. And then the environmental modification, something to think about as we go along. You need to identify and instruct behavioral modification. If you send a home program with the patient, the big thing is carryover. Are they going to actually do that or not? So talk to them about that, indicating that it's very important to get that accomplished. And then prevent injuries and unnecessary complications, making sure they stay on board with their medications. You might see them more often than they see their physician, so that's something you need to talk to them about. and then empower the individual to take charge and get that squared away. In the rehab challenges, we're talking about the chronicity of the problem, so it doesn't really go away, so you're going to have to deal with that. That you're not going to see changes instantly, you will see changes gradually. It's unpredictable, it's a variable course, so again, we don't know what actually causes the exacerbation of the MS, and hence it might be a trigger that might occur, who knows, right? Cognitive dysfunction again comes back to bite us if we don't take care of it. The invisible symptoms, for example, of fatigue, and we'll talk about that a whole lot more. Pain associated with any of the different disease levels, again, we can address. The anxiety, depression, well, again, how do we know that the patient is falling into that category? Do you do any of the written tests that you can provide for the patient to know where they're at in that process if you're seeing them fairly frequently? Assess them. If they fall into the anxiety or depression category, definitely need to deal with that as you go along. I know we're spending a lot of time outside of what we're actually talking about electrical stimulation, but you'll see that this ties in. If you don't deal with these pieces of the puzzle, then providing the treatment really is a moot point. Since there really is no cure for this process, they have to understand that and move on. Deconditioning is a huge piece of the puzzle, and we'll address that as we go through muscle reeducation, etc. And then realize lack of insurer support for the rehab services is a huge issue. So you're going to have to deal with that, whether or not they pay out of pocket or whether you see them infrequently. On average, my MS patients are seen once a month rather than 2 to 3 times a week. Does it make sense for them to come in if they're not going to make that much change? So bowel and bladder dysfunction is another piece of the puzzle you probably will not think that as a PT you should be able to address, but we'll address that in a little bit as well. And then the secondary and tertiary complications, multiple problems requiring your prioritization. So if they indeed have pain and that's limiting the ability to get around, are we going to address the mobility first, or are we going to address the pain? So that's something I think you have to pay attention to. So it's also driven by your patient identified priorities. I had a patient that came in very early in this process that was a marathon runner. Her only problem was that she had dropped foot. How do we deal with that? Give her AFOs. She went out and ran another marathon after she had AFOs. So that's what she wanted to do. She couldn't care less about the fact that she was emptying out her glass immediately running that marathon. That's what she lived for. And then be sensitive to interaction and fluctuation of the symptoms. Symptoms that can occur again that you cannot see, so you have to be very, very cognizant of that piece of the puzzle. You want to establish a functional baseline, so you want to start up front. So those tests that we generally do, and we'll talk about that later on, those standardized tests, do them up front, and then do them as you see the patient that might be appropriate, and we'll talk about that some more. Requires regular reassessment. So how often would you reassess an issue? If you were assessing pain, guess what? You are reassessing within minutes of providing the treatment. So make sure you're able to document that process and whether or not that carryover exists. Treatment obviously has to be cost effective and effective, and the goal here is effective. We want carryover, we want a significant outcome. So again, how do we get to that point and feel comfortable with that process? Collaborating with your co-treaters, certainly a nice way to do it. Like I said, if you're uncomfortable with dealing with the cognition piece, get that addressed by somebody else that can. If you're unhappy or unable to deal with the bowel and bladder issue, then get somebody else to deal with it, because that impacts your outcome as you start to provide treatment as well. And then the standardized assessment tools are the key and the way to go. The different domains we look at, again, gait and mobility, transfers, bed mobility, posture, tone, range of motion, gross function. We're looking at strength. Is it individual piece of strength? Do we care whether the extensor indices works, or do we care that the whole extensor component of the wrist actually works or not? Or do we care whether or not one muscle versus the entire group of muscles is out to lunch? Again, how do we assess with that? Fatigue is a huge piece, so we'll spend some more time in that. Sensation, if you're not used to assessing sensation, be aware that you need to do that. So if you haven't used the Siemens-Weinstein monofilaments in a while, pull it out, check them out, get some baseline data to see whether they're making any progress or not. As they lose a sensation, perhaps they lose the sensation piece of the puzzle. Remember, sensory fibers can turn into pain fibers. So how do we deal with that loss or gain, as the case may be? ADLs and IADLs are also something you want to work on. Work in leisure. For folks that are unable to get going and doing some activity that they like, depression will start to occur. With depression occurs decreased mobility. With decreased mobility, decreased function. So you can see that vicious cycle. Therefore, that becomes important as well. Pain, balance, vestibular, speech and swallowing, these pieces we can address. Pain and balance and vestibular we certainly can address. Speech and swallowing you're going to have to hand over, as is cognition. Safety can be addressed by all of us, all right? How do they deal with getting around? Are they safe when they even step out of their door? Or out of their bedroom, basically? And then dealing with the bladder, bowel, vision, sexual function, etc. If you're uncomfortable with that, again, you need to send them out. But send them out quickly so you're not waiting to deal with that unseen piece of the puzzle. Take a good medical history. Very important to know what their lifestyle is like or what other comorbidities exist. And then take a look at medications. Remember, if you don't know your medications, make sure you understand, because there's a whole list of medications that that MS patients generally have. Do they have appropriate equipment? So if they're unable to walk and your goal is just to get the contracture out, as in one of the videos that Amy showed at the last in-service or last course seminar, webinar, how do we deal with that? Do we have enough sufficient range of motion so that they can actually sit in a chair or get themselves to standing so that they can transfer from one point to the other? What is their self-care ability? Again, if they cannot move their arm, how do we get the pain out of the arm so that they can move? What are their environmental factors? What is their life phase activities? How do they go about the day-to-day function? Have you thought about fatigue management? If you use a toothbrush to regularly brush your teeth, how about if you use something a little bit more automatic, like an automatic toothbrush or a power toothbrush? Just simple tasks like that make a huge difference in reducing that fatigue factor. Are they actually going out and doing something, or are they housebound? Huge difference if they're stuck. So your goal would be to reduce the pain, increase the function, get them out so that they don't get depressed. If they're at work, how do we maintain their work status? Can we talk to them, their manager, and say, okay, perhaps if they're doing a lot of heavy-duty working, what kind of rest periods can they have? Working through that whole process. And then emotional status of the whole process, I'm not going to get any better, needs to be dealt with as well. So standardized treatment tools, remember there's a whole list of these, and these are just some things that are used fairly frequently for MS. If you don't have them, I'd be more than happy to send them along to you, but it's available out on the internet without any problems. So the MS functional composite, the 25-foot walk, 9-hole peg, the Passat, all things that you can look at, the MS quality of life 54, MS quality of life inventory, the MAC FIMS, or the expanded disability status scale, all of which you can use some point or the other. Don't forget, you have to address all the assessment tools are associated with aerobic fitness. How you deal with that? The equipment necessary, equipment assessment, an activity diary to give you an idea of whether or not they're on track or off, or whether or not they're overexpending their energy. Because if they are overexpending their energy, your input in treatment will not get you a good outcome. Are they getting sleep at all, or are they up all the time? If you have the ability to see these things and ability to refer them on to the physician and say, perhaps we need to look at a sleep study to see whether or not they're getting enough rest. If you're not familiar with the vestibular ocular assessment, then you certainly need to take a look at that. Just turning the head alone can cause them to feel off balance. So being able to assess that very quickly becomes important. Neuropsychological assessments, again, if you're unable to do something like that, you need to be sending them out, so don't wait. Safety evaluation we can all do, and definitely the gait evaluation. A lot of times I will videotape the patient up front to get a baseline so that I can actually see and compare down the line. In gait, you can address just one piece of the puzzle and get a phenomenal outcome. So if you're dealing with a spasticity, for example, in the ankle, reducing that spasticity using electrical stimulation, suddenly you have a gait pattern that's much improved, decreasing the balance limitations, improving their function. Taking a look at visual acuity, they're tracking peripheral vision, the visual perceptual assessment, something you can use. So the list goes on, right? The 6-minute walk, gait observation analysis, tandem walk, analysis of environment and tasks, the RAOs, cognitive assessment, perceived deficits questionnaire. Perceived is something that's very important. The patient needs, you need to know what the patient feels like, what the patient and where the patient feels like they're fatigued or where the patient feels like they're weak, to be able to provide some input. The affective disorders, again, symptoms to consider, the anxiety and depression, we talked about that. Heat intolerance, it's huge. So how do we deal with that whole process? Bowel and bladder dysfunction, as I said, it's huge. I'm going to give you an alternative to provide some treatment as far as that's concerned. Low vision, get glasses on if necessary, or send them out to get that squared away. And the speech and swallowing, and the sexual dysfunction, obviously, you need probably send them out, if not, if they're not doing well. All right, let's get to the meat and potatoes at this point. When we deal with MS, fatigue in MS, it's persistent, it's overwhelming. There's a sense of tiredness and exhaustion. Reduced conduction of the nerve impulses is why it does occur, right? Excessive spasticity or muscle tightness, as Amy pointed out before, can produce that fatigue. Increased core temperature due to the weather or fever exertion can again provide that fatigue. So having them manage that temperature is important. General deconditioning and decreased trunk stability also can reduce the increase the fatigue in a patient with MS. The aggravating factors include obesity, sleep disruption, restless leg syndrome, inactivity or overactivity. I highlighted that only because that's where we come in, right? Side effects of medications, again, cannot tell you enough. Make sure you know what they are. Depression, stress, and other medical conditions such as anemia and hypothyroidism. So we're dealing with MS, it's fatigue in MS, it's classified into a central as well as peripheral association with the CNS or peripheral neuromuscular system. In this particular article by Kent Brown, it suggests that persons with MS experience high levels of central fatigue rather than, relative to non-disabled individuals. Central fatigue with patients with MS associated with the impairment of the neurotransmission due to demyelination, and therefore resulting in nerves fatiguing rapidly. Lenman suggested that the patients with MS show greater fatigability and greater slowing of the anterior tibialis muscle relaxation after repetitive stimulation at 40 Hz, suggesting that patients with MS experience high levels of peripheral fatigue compared to non-disabled individuals. So again, both central as well as peripheral becomes an issue. Currently, there are no therapeutic strategies designed to specifically for patients with MS that are prone to central fatigue, except that FES can activate these muscles and bypass the CNS to improve strength. With post-radiculopathy, etc., with stroke-related pieces, and chronic heart failure. And let's take it to the next level. Studies have also reported that E-stim in an intensity above motor threshold have led to increased motor cortex excitability, suggesting that surface FES might be effective in overcoming central fatigue. So if you think about this, yes, we can be effective using electrical stimulation that way. Central fatigue, primary limitation during voluntary exercise of individuals with MS, since the peripheral neuromuscular system might not receive sufficient level of training through voluntary exercise regimens. Central fatigue is weighted more than 5 times higher than peripheral fatigue. In this particular article by Chang, 8 weeks of FES and surface FES training led to improvements in general fatigue, central fatigue, and perception of fatigue in in patients with MS. So again, there's research to support the use of electrical stimulation to help you get to that point. Chang's study also suggested that a home-based FES does not require activation of the CNS as safe and effective training for the patient with MS. And oftentimes I will send home the muscle stimulator with the patient with the intent that they're going to be able to get that outcome without me being there and without them having to waste the energy to come into the clinic. Right, why does Russian stimulation work? Because during voluntary contraction, motor units are recruited asynchronously and according to the size principle in order from slow type 1 to fast type 2 motor units, which means that electrically invoked contraction, motor units fire synchronously in reverse order from type fast type 2 units to the slow type 1 units, which means now we can get power, we can get function if we use electrical stimulation instead of the slow postural type fibers. Combination of the two gives us the reverse order and recruitment of external loading, so you can get hypertrophy. Yes, you can get increased strength in patients with MS imposed on stimulated muscles during training and are likely to be responsible for the gains observed during NMES training. If we talk about NMES, we talk about FES. They're really all electrical stimulation, just different terms for how we strengthen the muscle. Studies suggest that 30% more force than maximum voluntary contraction can be had with electrical stimulation. This is Selkowitz in 1985. Studies suggest that E-stim for muscle re-education producing lasting gains through a short-term training regimen. I know you're saying approximately 30 training sessions, right? But 30 training might be only one with you and the rest with the patient at home with their portable unit. So realize that it's not necessarily something that you can do. Here are all the studies. Incidentally, if you want the references, I'll be more than happy to send them to you. Otherwise, they're all located throughout the presentation. Parameters that you need to pay attention to. If you're dealing with large muscles, we're looking to 90 to 100% maximal volitional contraction. So here we're talking about the quads and the hamstrings, the butt muscles primarily, and perhaps the back extensor muscles or the abdominals, as maximal volitional contraction should be 90 to 100%. If we're dealing with the anterior tib, then we're only dealing with 50% maximal volitional contraction, being a much smaller muscle as opposed to the quads or the hamstrings. Number of repetitions becomes important. Can you get an outcome with overloading the muscle with 10 repetitions? And the answer is absolutely yes. Can we get the number of training sessions down to 1, potentially, and another revisit so that they can come in, get the training, get the unit, go home and do it themselves and get the outcome. Specificity of training is where you come in. Very importantly, you need to assess which muscles are up to lunch. Don't do a shotgun approach. They don't have the time, they don't have the energy. So you have to know which muscles to turn on. All right, so when you do the muscle testing or when you assess gait, you need to be aware of which ones they are. When we deal with primary weakness in MS, this is due to the MS plaques in the brain or spinal cord. Again, talking about fatigue, paresis, or paralysis, common in anti-gravity muscles. Secondary is due to disuse, deconditioning, compensatory movements, prolonged stretch, contractures, pain, proprioceptive loss, tendonitis, etc. Contributing factors are the spasticity and the ataxia, both of which we can address very, very nicely. Trunk, abdominal, and gluteal weakness secondary to prolonged sitting occurs. How many of our MS patients that are in the later stages are stuck in a wheelchair? Right, often exacerbated by adaptive shortening of the hip flexors and contributes to poor posture and balance problems in standing. So they're sitting for a long period of time. They might get a contraction in the knee, might prevent them from standing ever again, which is just as important for them, as you'll see in just a little bit. Neck and trapezius weakness secondary to poor sitting posture and inactivity results in decreased arm function in overhead reach and is exacerbated by tightness in the pec major and latissimus dorsi in upper trapezius, all of which you're going to be able to address. So taking a look at foot drop primarily, we can deal with circumduction, shuffling, etc., but we'll take a look at foot drop as the primary treatment process as we go through this training. So if you take a look at the ankle dorsiflexor, again, the tibialis anterior is what we're dealing with. Here are your parameters. I put it down only because I'm sure you want to address this with your device. If you look on the picture, you will be able to see a square and a circle. The circle will determine where your motor point will go, in this case the black electrode, and the square will represent the rate or the dispersive electrode. Note that the electrodes are very close together. The further apart you put your electrodes, the deeper an application you get. So if you put them too far apart, you might end up getting the calf muscles instead of what should be the anterior tibialis. So pay attention to where you put the electrodes and the size of the electrodes that you use. So typically, electrode for the anterior tibialis may no more be than 2 by 2 rather than a 4 by 2 electrode. All right, so when we're dealing with strength, the carrier frequency is going to be 5,000. Depends on your device. Can be anywhere from 2,500 to 5,000, and in some devices up to 10,000 hertz. Why does that become important? It becomes important because of comfort. Have you tried a high volt current unit lately? very uncomfortable, as opposed to a medium frequency device that we're talking about at 5,000 hertz. So your medium frequency devices run anywhere from 25 to 10,000 hertz as their carrier frequency. Pulse width is usually fixed. You have no choice about that. If you have an option, then you want to increase the pulse width to as wide as will go. It's much more comfortable for the patient and will allow you to get a larger, if you would, a contraction, so that you can overload the muscle at the appropriate rate. Talking about pulse rate, it's anywhere from 35 to 70 pulses per second. And based upon what I've done most times, it's 50 pulses per second across the board. So that'll make it a lot simpler, so you don't have to remember a whole bunch of parameters. If we're dealing with strength, then the on time or ramp time is going to be 2 seconds. The ramp down time is 2 seconds. So if the on time is 10 seconds, your total time in technique is only 6, not a very long time. So how do we get increases in strength? As we discussed earlier, Russian stim works very well. Russian stim is your muscle reeducation piece of the puzzle. 50 seconds off, so 10 on, 50 off. So 1 in 5 is something you can shoot for. I've oftentimes gone 1 in 3, that's correct. So 10 on and 30 seconds off rather than the 10 on, 50 off. You want the time for the muscle to rest. If you never let the muscle rest, then it has no chance to repolarize again down the line. So definitely pay attention to that. If we're dealing with power, what's the difference between power and strength is really the on-off times and the ramp times. Note that the ramp times, instead of being 2 seconds for strength, is now 1 second. You're hitting that quick on and quick off mode. But guess what? You're also not on for very long. So this is where you talk about your FES piece of the puzzle, where you want a function to occur and it's gone. Right? So 4 seconds on, 12 seconds off. The pulse rate and the carrier frequency remain the same. Those don't change. Electrode placements don't change either. So you're adjusting the parameters primarily to get whether you're dealing with strength or power. So muscles of ambulation, here it is during the stance phase. Pay attention. If you see a patient struggling in any of these phases, right, if they cannot get toe off, look at all those muscles associated with toe off, right? So you need to be able to assess the strength related to that. Here's the breakdown so that you can see which one's tied to which one. On we go. That's all I wanted to say about that. All right, so other options to address fatigue, in this case, not only just strength alone, but we're dealing with 3 other groups that were used to determine what was most effective against fatigue. Group 1, no exercise. Group 2, stretching and strengthening. And Group 3, aerobic exercise. Well, guess what? Aerobic exercise was found to have the most improvement in the reported fatigue, walking speed, walking distance, and health-related quality of life. How often do we get our MS patients into a quote-unquote aerobic activity? Not enough. So perhaps on top of this, being able to get them to walk in a body weight supported system might be the way to go. So to either taking out the Lactate or the Locomat or even the Biodex devices, being able to offload them will get them the ability to get their aerobic capacity kicked in. So now you can tie in the correction of the muscle strength piece of the puzzle. You can tie it into a functional piece of the puzzle to get them going, get their aerobic capacity up, reduce their fatigue. Quite the opposite from what we used to do with MS patients. Oh, you don't need to work out because it's just going to make you worse. So the research supports that you actually need to get them up and get them pushing a lot harder than before. So when you're considering a strengthening regimen, what you need to look at is progressive resistive exercise will not be effective if the weakness is due to demyelinization in the pyramidal tracts. It will only increase fatigue and thus weakness. An unaffected muscle group should be maximally strengthened to allow for compensation. So here's where you want to turn on the muscles that are weaker. If they're beyond able to turn on, you're in trouble. So you need to be able to get those turned on. So remember that muscles work in pairs. So dealing with that concentric versus eccentric function of each muscle, you need to deal with as well. You need to work with the antagonistic versus the agonistic muscles to get the outcome that you need for gait, get the outcome that you need for function. Emphasize proximal strengthening to decrease the energy expenditure. So core muscles both in the upper trunk and the lower trunk certainly need to be addressed. so you can get that ability to move the arm or the leg or even the trunk in transfers. Prior to strengthening, stretching should be performed to decrease spasticity, improve blood flow, and decrease flexibility. So some things that you want to consider when you're actually doing a strengthening regimen. And when I say strengthening regimen, we're talking about both power and strength as well. Right, we already covered the primary weakness. So in primary weakness, we want to deal with strengthening the muscles, requires the compensatory intervention of mobility aids and bracing, etc. Secondary weakness can be overlooked. This is minimized with early intervention. There it is again. And appropriate follow-up to maintain posture and stability, correct compensatory gaits, encourage a healthy lifestyle, and teach energy management strategies. Again, this is so critical. Your outcomes are going to depend on something like this. So if they're just diagnosed with MS, that's the best time to see somebody so that you can set up this healthy lifestyle, so that they can set up procedures in place so that they know not to fatigue themselves, or they know not to end up with spasticity that they cannot control, and move on. So other pieces of the puzzle. So if we're dealing with gluteals, sure, we can do isometrics, we can do sit to stand, we can do bridging, we can do prone activities and hip abduction. Incidentally, one of the biggest exercises that we see for those, you'll see in a second, having to do with clamshells. So, well, unfortunately, that's not the best way to actually strengthen the gluteals anymore. Dealing with the low abdominals, we can do pelvic tilts and tummy tucks, modified abdominals, modified in forearm prop and sitting. All these exercises that we know how to do, now you're going to add another piece to the puzzle, and that's using electrical stimulation to get the best outcome, because you're going to overload that muscle. For one, you're going to get 30% more function. You're going to get the fast twitch fibers, which are related to function and not just posture. And you're not going to increase fatigue. So when we deal with the glutes, here it is for the power mode. Note that the parameters have not changed. The electrode placements have changed, but you can apply this to any muscle in the body. So when we're dealing with gluteals, again, take a look at the circle versus a square, which will tell you exactly where your positive and negatives go. So remember, the circle represents the negative pull, or your and then the square represents the positive pole, which is your red electrode. So making sure you have the electrodes in the right position will be essential to get the motor point, which is typically where the black electrode goes, to get the best contraction. So if you have the gluteals, obviously it's a fairly deep muscle. How far apart do you put the electrode? A lot further apart than if you would when you're dealing with the anterior tibialis. So pay attention to that. If you get a different contraction and you don't get what you're looking for, just adjust your electrodes, and that may be all that you need, rather than trying to fiddle-fart around with your pulse rate. Stick your pulse rate at 50, and then address your electrode placement and see what kind of outcomes you get. If you get stuck and you don't see an outcome, then perhaps addressing your pulse rate might be another way to go to get that contraction you're looking for. As I said, with power, it's the same sequence. The ramp time up is 1, ramp time down is 1 second apiece. On for 4 seconds, off for 12 seconds, so pretty fast. So here's the clamshells. Can you do clamshells together with electrical stimulation? The answer is yes. The latest study, however, we're looking at a 2009 July out of what is the Journal of Orthopedic and Sports Physical Therapy, and they're suggesting that clamshells are no longer the gold standard, but side-lying, abduction, and extension is the gold standard to get the strength of the gluteals taken care of. Take in consideration that if the patient cannot accomplish a side-lying leg lift, then this clamshell might be a good alternative to get that same muscle stronger. Taking a look at the abdominals. The rectus abdominis here, or the obliques, can certainly be addressed the same way. Notice that there are bajillion electrodes up and down on this rectus. You don't need that many. Electrodes come in a variety of sizes. So there are electrodes that would be able to envelope the entire series of rectus muscles all the way up and down. Electrodes can come a foot long as well. All right, so did the parameters change? No. If I'm dealing with power in a different muscle group, it's the same parameters no matter how you cut it. So it makes it simpler. Here it is in the iliocostalis. So something else to consider is the back extensors. Here's the strength mode again. I put it in again because here's the parameter. It did not change, guys. So it's the same set. So don't get caught up with the parameters. Get caught up with assessing the patient appropriately, picking the right muscle to strengthen, and then you'll be able to do it just as well. I talked about pelvic floor, didn't I? Increasing pelvic floor strength you can accomplish with electrical stimulation. This is a crisscross format, so the A's represent one channel and the B's represent the second channel. In this case, you're going through the body to get the pelvic floor to increase in strength. Why is this important? You're going to be able to control the sphincter. If you can control the sphincter, you can control incontinence. So you can control how the bladder fires. So they have a lot of problems associated with incontinence. Here is a way to do it. Can you do power with this one? Sure you can, but you're more interested in strength than in power in this instance. So again, applying, what did I say for strength? Is the same. Ramp time up, 2 seconds. Ramp time down, 2 seconds. On time is 10, off time is 50. The treatment time is no more than 10 minutes, 10 repetitions, guys. That's all that it takes. But with maximum volitional contraction, you can shoot for 90 to 100% at this point in getting that contraction to occur. So energy management strategies are another piece that I like to present. Is you're taking a look at the 4 P's. So pacing, planning, prioritization, and positioning. How do we deal with that piece of the puzzle if the patient is emptying out their glass at the beginning of the day when they have to go out in the evening to their kids' football game, and they are unable to do that? That leads to that whole cycle again of breaking down. So you need to walk them through this process. We have the tools to be able to strengthen. We have the tools to be able to get the power back in. But with that in mind, take a look at when needs to be done. Make sure you adjust your home and work schedule. Make sure you look at the warning signals when you are tired. If you're tired, you're tired. There's not much you can do. One of the rules of thumb working with exercise right off the bat, remember, is that for every minute of exercise, you need a minute of rest. Rest is just as important with a patient with MS. So pay attention to that piece of the puzzle as well. Make sure you use the compensatory strategies, and we'll talk about some of those in just a little bit. Acceptance of requests for assistance. Here's your target rate in terms of exertion. I'm going to be moderate. So if I'm working through an exercise, if I'm working through the gluteals, if I'm working through gait, and I'm using the electrical stimulation, then my exertion level should be moderate. If you go more than that, likelihood of being fatigued is much, much more. Control of spasticity is the next piece of the puzzle that I want to talk about. So we'll move on. Again, we have medications that can address that piece of the puzzle. Spasticity is a result of imbalance in electrical signals coming from the brain and the spinal cord, often caused by damage to these areas. Imbalance can cause hyperactive muscle stretch reflexes, which result in involuntary contractions of the muscle and increase muscle tension. So spasticity can become from poor balance pieces of the puzzle. Hence, the vestibular and balance tests need to be done. Can occur either a sustained stiffness caused by increased muscle tone or spasm that come and go, especially in the night, might result in pain. Well, I can get rid of the pain. That's not a big deal. Can produce pain and tightness in and around joints or in the low back. So being able to reduce that pain becomes fairly critical. Intensity of the spasticity may vary depending on position, posture, and state of relaxation. And really, in any case, we should be able to get rid of that spasticity nicely. So it's common, again, coexists with weakness, may present early in the disease, may be phasic spasm or sustained. Consequences: pain, contractures, energy expenditure, skin breakdown, breathing problems, hampers gait and transfers. So spasticity is huge that we need to deal with. All right. Considerations, again, dealing with the tone and the bulk. How do we deal with that strength? We already talked about. How do we deal with power? We already talked about that. By default, using electrical stimulation, you also increase the circulatory function at the site. Getting them up and moving increases circulation, allows function to work a lot better. You can prevent the deep vein thrombosis piece of the puzzle, assisting with activities of daily living if you reduce spasticity, and assist with postural control. So in taking a look at this particular study by Potisk, it's suggesting that using TENS at 100 pulses per second can get the outcome after stroke. Taking it a little bit further, in this particular instance, 18 out of 20 patients, mild but significantly, statistically significant decrease in resistive forces and all consequences or frequencies of passive ankle movements are recorded following a 20-minute application of TENS. Now don't get caught up with the portable unit is not appropriate. You can use that as well. Effective TENS persisted 45 minutes after the end of TENS. Results in the study supported the hypothesis that the TENS applied to the sural nerve may induce short-term post-stimulation inhibitory effects in abnormally enhanced stretch reflex activity in spasticity in the cerebral origin. So yes, you can use that piece of the puzzle in this particular Miller text. Suggests that while TENS does not appear to be effective in reducing spasticity, longer applications may be useful in treating. So in this case, we're looking at 100 pulses per second, but guess what? It's below motor threshold in 8 hours. When was the last time you used TENS for 8 hours? Different idea. All right. So again, most patients in the study reported gain relief for a number of hours, with some reporting benefits up to 48 hours with repeated applications. The nice part about this is that the side effects are none, so you should be able to do that nicely. So I've given you the application for the sural nerve. You can put it on both legs if you choose to do so. Just need to make sure your lead wires are long enough so that it can run up the pants, so that you can use it without having to wait around for the treatment to occur at 8 hours. Bummer if you're stuck, right? No. So get them up and move them around. Hook up the TENS unit, 100 pulses per second. Pulse width is 112 microseconds. Remember, the intensity is comfort, below slight motor twitch, up to an 8-hour application. So if you have I've tried this and it has worked in some of my patients. It's not always consistent, but another tool to address spasticity. How do I decrease spasticity with Russian stimulation? This is fatiguing the muscle. So the pulse width again as wide as it will go. The rate is about the same, 35 to 75 pulses or 70 pulses per second. The ramp time is 2 and the ramp time is down. But now guess what? Your on time is 10 and your off time is 10. So you can actually get fatigue of the muscle. Another way to do it is through reciprocal inhibition. So turning on the antagonist to turn off the agonist. So if you're having a lot of spasticity that's occurring in the hamstrings, being able to turn on your quads using this technique might be another way to look at it. Nerve block pain modulation is another cool tool. Remember the patient that Amy showed with her lying sideline and trying to determine whether it was tone or whether it was a contracture. This is another way to go ahead and determine that. So nerve block pain modulation, first applied at sensory levels, progressively accommodation, and with progressive accommodation until a patient no longer perceives the current. Bottom line is that you're increasing the intensity gradually throughout the process because you get accommodation very quickly. If you take a look at the stimulation parameters, a phase duration, don't worry about that, usually fixed again. What is not fixed is your frequency. Your frequency, this is not it. This is your carrier frequency. Your frequency is a 0 pulses per second. So you have to turn your device down to a 0. Let your carrier frequency do the work for you. In amplitude is moderate to strong sensory. Sensation diminishes. You need to increase so that they can get to that sensory level again. And the depth of nerve block is achieved. And nerve block means that the muscle is no longer firing. This is your Widenski inhibition. It's actually preventing the nerve from recovering and allowing that nerve. It's essentially like taking the pedals to somebody that's in having AFib, all right, or having tachycardia where the heart stopped. You want to stop the nerve from functioning and hoping the fact that when it returns, that spasticity will go away. Oops, move on to the next page. Application technique, you'll need to apply this directly over the area, above and below the area that which you need to cause a decrease in function, if you would. You can either apply bipolar, 2 electrodes, or quadpolar, 4 electrodes. Onset is immediate, right? As soon as you get that nerve block, or as soon as you get that nerve from malfiring, that is done. You're ready to move on to see whether it is truly a contracture or truly a tone piece of the puzzle. If it's high tone, you'll be able to extend it to be able, or in this case, to extend the knee to determine whether or not that's tone or contracture. If you're dealing with a contracture, then that's a whole different ball of wax versus dealing with tone. Clinical indications, that's pretty much any time you want to reduce acute pain or any time you want to use a means of stretching, a means of decreasing muscle spasm or reducing spasticity. Very nice tool. If you haven't used it, I would encourage you to try that out. Alright, so here it is applying for the hamstrings. Again, your parameters are basically your carrier frequency, anywhere from 2500 to 1000. Your pulse rate is 0. Cannot repeat that enough. Your pulse rate is 0. Alright, so above and below the area you want to cause nerve block. So if I was going to stretch out, or that tight patient that we saw, applying the electrodes in these positions will potentially determine whether or not it's high tone or a contracture. If it's high tone, by default this should open up and you should not have that tightness any longer. Once you have the tightness resolved, then you can weight bear, reduce some of the tone using some of the Bobeth principles. So how does it work if you're using a two-channel piece of the puzzle? You can certainly get an outcome that way. Notice that the electrodes have a slightly different position. These electrodes might have to be larger in order to accommodate the area you're trying to treat. Alright, last but not least, let's deal with pain. 40 to 60% of patients with MS report pain as a significant problem. Whether it's due to spasticity, whether it's due to injury, whether it's due to just pain in general. Types of pain can be central, offering burning pins and needles, or myofascial pain, or spasticity, or peripheral nerve injuries, all of which you will be able to address with management of using electrical stimulation. Other pain can be used from contractures, as we saw with that patient in Amy's presentation. The decubitus ulcers can cause pain as well. Weakness and muscle imbalance, because of the imbalance, can cause inappropriate joint movement and certainly pain associated with that. Compensation for the weakness in some muscle groups, and then definitely overuse, using the wrong muscle to overcompensate for the function. And then secondary to movement dysfunction and posture, you have back, neck, and shoulder pain, hip, knee, foot, and ankle pain, all of which we're going to be able to address very easily. Medications, piece of cake, right? Not all the time. Remember that medications have side effects, so be aware of that process. So when we're dealing with this, we want to correct that muscle imbalance in the first place. Just killing off the pain is not the only thing that you have to do. So you have to address that muscle imbalance. Take a look at your seating positioning pieces. Take a look at how they should be able to relax. Use biofeedback, use hypnosis if necessary. And then the modalities. All right, we're going to get primarily to use electrical stimulation. Again, don't get caught up with the words TENS, right? All electrical stimulation is transcutaneous. So pain modulation theories, there are two basically that we're going to deal with. One is the gate control theory. So we're going to send pain up, we're going to shut that gate down by the Melzack and Wall theory in 1965. Again, the sensory perception of pain is a result of activation of the transmission cells in the dorsal horn of the spinal cord, resulting from a balance of peripheral input along large diameter, and here's the key word, large diameter and small diameter afferent fibers. Electrical stimulation falls on larger diameter efferent fibers and hence activates the inhibitory neurons. Basically, it beats the pain to the brain, shuts the gate off, inhibiting that T cell from sending the information further up into the brain. Is the pain still there? Absolutely. And that's why we have to address the other pieces that cause the pain. Is there a muscle imbalance? Is there a problem with gait and hence the inappropriate use of that particular joint? How do we deal with that piece of the puzzle? The second supposition of why there's pain relief is the endogenous opiate theory. At certain frequencies, 100 pulses per second, your brain actually produces something called dynorphin, filling the kappa receptor for an X amount of time. So by default, if I use 100 pulses per second for pain management, my onset of pain relief is usually within 5 to 10 minutes, but my duration of pain relief only lasts 30 minutes to 2 hours. If I was using motor analgesia at 2 pulses per second, it fills the mu receptor with what is beta endorphin. Now the outcome is anywhere from 5 to 6 hours. Onset was 30 minutes. So I'm going to get quick pain relief. I'm also going to get the ability to manage the pain for a long period of time, which is certainly good and bad. So in sensory pain modulation, this is stimulation that's applied at sensory levels to a slight motor twitch. Stimulation parameters, the only one that you need to remember is 100 pulses per second. I know that gives a range because that's what literature suggests, but 100 pulses per second is what you need to remember. The intensity is to a slight motor twitch. We want to get past that first level, if you would, the two A alpha and delta pain fibers, so you can get into the C fiber, which is the chronic pain fiber. And remember, your strength duration curve is that it indicates that you have to get past the motor fiber in order for that to occur. The mechanism of action is the gate control theory and the endogenous opiate theory. The application technique we'll talk about in just a little bit. It's primarily going to be 4 electrodes in a crisscross format. Onset and duration of relief, again, rapid within 20 minutes, but now lasts up to 2 hours. And here's what you can do. Just about anything with pain. So realize that that's what it is. In motor pain modulation, the only thing that you need to remember in this one is the pulse rate. All right, the pulse rate is going to be 2 pulses per second. The intensity is definitely to a motor twitch at this point. The mechanism of action is not any different. It's still a gate control theory. It's still the endogenous opiate theory. The electrode placement is not any different. So I'm trying to get to the electrode placement, can you tell? Onset of duration of pain relief is 30 minutes onset. Duration of pain relief is up to 2 to 6 hours, and that should be actually 5 to 6 hours because that's typically what I get with my patients. Clinical indications, anytime you want long-term pain relief, is when you use motor analgesia. So best both worlds, you're going to hook both together, both sensory and motor analgesia in the same treatment. All right. Parameters are still going to be 15 minutes on 100 pulses per second and 15 minutes on 2 pulses per second for a full 30-minute treatment. Gives you quick pain relief but long-lasting outcome. The same technique is used in terms of onset. Right, electrode placement, fairly important. Right, so I'm going to spend a little bit more time on this piece of the puzzle. This is acupuncture points, and remember that you cannot document this in your notes as acupuncture points, however you can put them as trigger points. As a precursor to this, make sure that your patient is not pregnant. These are also spontaneous abortion points, so you have to watch out for that. So B1 and R1 go together. One is red and one is black. So the black goes between the thumb and index finger in the web space, and R1 goes at the tip of the elbow crease. All right, so there's one channel. The second channel is B2, which is just barely touching what is the, in this case, the ulnar bone, the head of the ulna. And directly opposite that is R2, or the red electrode. Between these 4 electrodes, you can kill off any pain anywhere in the body using that sensory or motor analgesia ideology. So the parameters are already talked about. Now we're talking about where the electrodes go. Yes, pain anywhere in the body. If you don't believe it, try it out. Most of my patients are pain-free in my clinic within 10 or 15 minutes at the most. Contraindications with electrical stimulation. Pacemaker is contraindicated because the manufacturer says, no, I cannot do that. However, I've used it over the pacemaker before and without any side effects. Just be careful. Remember, it's your license, not mine. Cancer. If the patient has an active tumor, if it's not in remission, this is something you don't want to do. Electrical stimulation increases circulation and hence the possibility of causing what is metastasis, right? So you want to watch out for that. Never over transcerebrally, never transcranially, and never over the thoracic region either. If there's a danger of hemorrhage, you do not want to use electrical stimulation. Never transthoracic, as I talked about. Patients with epilepsy you should monitor because we're not quite sure whether electrical stimulation will cause that to happen. And then do not apply it in the vicinity of healing tissue, in this case post-surgical. For most instances, so if you have a wound and you want to cause healing, again, if they're not totally healed in that phase, you certainly want to deal with not putting electrodes there. That is the end, believe it or not. I've talked to you for an hour. If you have questions, now's the time to post it. Again, I will make sure that you read on the bottom of your screen to do the survey and the post-test questions. But if there's any questions at this point, I will entertain it. And if you don't want to ask the questions, please email me. I'll be more than happy to do that for you. By way of introduction, I am Keith Koo, and I work at the Oklahoma Neurological Center of Excellence, which is a a movement disorder facility as well as a vestibular rehab facility. Any questions? If I succeeded in confounding everybody, right?